Hello, I'm Melissa Fox and I'm CEO of Health Consumers Queensland. It's bittersweet to be here for our fourth and final episode of HCQ TV. Thank you to everyone who's been joining us. I'm honoured to be joining you today from the land of the Turrbal and the Yagara people, on which sovereignty has never been ceded. We pay our deepest respects to elders past, present and future. Now, I'm delighted to share a message from one of our biggest and most senior champions of both consumer partnerships as well as consumers being empowered to receive and be offered value-based healthcare, care that matters to them. Dr. John Wakefield used to be a GP, then moved into medical administration, headed up patient safety within Queensland Health, and is now Director General of Queensland Health, the most senior member of the Queensland State Health Department, the link between the department and the Minister's office. We are delighted to have him join us via video today.
Hi everyone, John Wakefield's my name, DG Queensland Health. Just got back from a big day in Townsville with the Minister, a great day. I'm in my car, it's 8 o'clock at night, but I'm really determined to contribute to your really important section on value-based healthcare. International evidence suggests that as much as 30% of current healthcare is not actually consistent with best evidence, and it confers little or even no benefit to patients. And a further 10% of healthcare actually causes harm. Now, at the heart of value-based healthcare is ensuring that the care that's provided is consistent with the best evidence and is also centered around the patient's wishes. So that is, after being informed of the facts from the practitioner and actually doing your own research as well, that the patient decides what's best for them. Now that's easy for me to say as a health professional, and I know it's really hard to achieve in practice, especially for a patient when they feel they're being told what they need by a doctor or another provider. Examples of this can range from being started on a medication, like a blood pressure medication, or to being told you need an operation. And it can be especially difficult for people with serious conditions such as cancer, where the treatment itself can really make you feel, it can be dangerous or make you feel really ill. And I think patients often feel scared to question the doctor's decision, and they don't know how to approach this, especially when they're already stressed or dealing with major decisions. It's very stressful and very difficult. So how do we make it simple for patients and their families to ensure they know all the facts and the options and that they can take charge of what's right for them? Well, I've got a simple mnemonic which can be used in every consultation, big or small, and it's BRAN, B-R-A-N. So whenever you're faced with treatment recommendations from a health professional, big or small, tell them that you want it with BRAN. You want to know the benefits, that's the B, the benefits of the proposed treatment. What are the chances that this will help you, and how? For example, if pain is your problem, what's the evidence that what they're recommending will actually reduce or eliminate this pain? You want to know the risks of the proposed treatment. What could go wrong, and in what proportion of cases? Every treatment carries risks, so never believe that when you're told that there's no risk to a treatment. That is just not true. Thirdly, you want to know what are the alternatives. That's the A. What are the alternatives here? Now, I'm a doctor. Doctors may and often do have, for the right reasons, their preferred treatment. But there's always alternatives, and those alternatives may be something that you prefer. So what are the benefits and risks of these alternatives compared with what you're being recommended? And finally, and this is really important, the N. What is the nil option? And there are so many times when you really need to ask that. So, doctor, is this urgent? Is this decision urgent? what would happen if I don't do anything now, if I just wait? And very often, and perhaps with quite a few surgical interventions, for example, there is often reasonable evidence that taking that nil decision or watching and waiting is no different. The outcomes are no different to those who have conservative treatment. But you must ask for the evidence for that, because it's really important that the expert that's providing you with this advice is telling you all of that, and you're getting it from a trusted source. So unless your decision's an emergency, when time is of the essence, there's always time then to consider these options, find out more, and even seek a second opinion. Because what matters is that you can make a decision that's right for you, armed with all the facts about what matters to you and what's important for you and your family. So my message to consumers tonight, and to clinicians, because we have to train clinicians not only to be ready for these questions, but to actually suggest that as well. So they make it easy for often frightened consumers to feel safe to ask these questions. So my message to both consumers and clinicians in the audience tonight is really clear. Bran is best. Thank you.
Well, thanks, John. That was Dr. John Wakefield, Director General of Queensland Health. And I can see the bumper sticker or the new campaign now. Healthcare, tell them that you want it with Bran. But why don't we get all of our care with Bran? And is there willingness and is there time to get our care with Bran? So we're going to dive deep into this issue this evening, and we've got a fantastic panel with which to do so. We look forward to welcoming John and the Health Minister, who was unable to be with us this evening due to travel at our annual event, hopefully face-to-face next year. But for now, here we are online. So for those of you joining us online, what does the term value-based healthcare mean to you? It's a term that's not well understood, or perhaps has different understandings by different people, and yet it's a concept that, as we've heard and as we will hear, is key to consumers getting the very best health outcomes, physically, emotionally and culturally. COVID has shown us just how precious our healthcare system is, and so reducing any healthcare that is not going to benefit patients is as important as ever. So, to delve into this important topic, we welcome our panellists. In the studio, we have Helen Mees. Helen served as the inaugural chair of Health Consumers Queensland's Consumer Advisory Group and is actively involved with Kidney Health Australia. Helen is a passionate and committed health consumer representative who never hesitates to remind decision makers of the importance of including consumers in decisions that affect them, whether it's as individuals, for their families, or with the system. Welcome, Helen.
Thank you.
Also in the studio this evening, I have Dr. Mornay Terreblanche, who has several roles working across both Sunshine Coast HHS and with other agencies. So Mornay is Senior Medical Officer, Anaesthetics and at the Sunshine Coast. He's also Medical Lead of Safety and Quality at Sunshine Coast HHS. He's co-chair of Sunshine Coast HHS Clinical Council, chair of the local Choosing Wisely faculty, and also co-chair of SwapNet, the statewide anaesthetic and perioperative network. Welcome, Mornay.
Thank you very much.
Also via video, we have two panellists with us this evening. So firstly, we have Dr. Joan Carlini. Joan is an active consumer representative and the until recent chair of the Gold Coast HHS Consumer Advisory Group. Joan is also a lecturer and researcher who is an expert in marketing, person-centred approaches in health and engagement, working collaboratively with a range of stakeholders driving policy change. Welcome, Joan.
Thank you.
And Harpreet Kalsi completes tonight's panel. Harpreet has worked with marginalised communities in Australia and abroad, specialising in health and wellbeing. She is a consumer representative with Clinical Excellence Queensland within Queensland Health and is on a number of care at the end of life working groups, along with being a consumer representative for Palliative Care Australia and director at Aboriginal Social Change Agency, Cox in All Ridgeway. Welcome, Harpreet.
Thanks, Melissa.
So, firstly, let's work out what we're talking about here. Joan, what is value-based healthcare?
Hi, Melissa. Hi, everyone. Values-based healthcare is really healthcare that provides significant benefit to the person at the centre of care. I think the important thing is that it can vary. So depending on person to person and their different values, different treatments will have different forms of value to them. So that's what makes values-based healthcare a little bit complex, because, you know, we can have high and low benefit care, but also there is differences between people that can distinguish that type of care as well.
Yep, understand that. Thanks, Joan. So, Mornay, consumers working with your Choosing Wisely faculty made a push for a change in terminology around the use of the term value-based healthcare. Firstly, can you briefly tell us what Choosing Wisely is and why does it matter what we call value-based healthcare?
Thanks, Melissa. So a few years ago, when we were looking at low value care, Choosing Wisely was seen as a vehicle to sort of get rid of low value care, if you like. Choosing Wisely is an international initiative that's really there to empower both consumers and clinicians to have a conversation about their care and, you know, what's best for them. When we had our first faculty, and I have to say one thing we're very proud of is that from the beginning we've included several consumers. So at the moment we've got 5 consumers on our faculty. And at the very first meeting, one of the consumers put a hand up and say, listen, we don't like talking about low value care. Because if you, Choosing Wisely, because it originated in the States, it felt to them that we were talking about money. It was about, well, we can't afford to provide this care, therefore you're not going to get it. And that was not what it was about. It was about, like Joan has said, you know, it's doing what's best for the individual. What's the benefit for that particular individual? And like she's mentioned, you know, one operation may be really of benefit to one person, but maybe a really bad thing to the other. So with Choosing Wisely, we've got and John has already alluded to the questions that we encourage consumers to ask their clinicians. Brand, we've added a D through COVID, and the D is for delivery mode, because I think one thing we've learned too is that care can be delivered in many different ways. And that's another question I think in the future that our consumers need to ask is, what's the delivery mode? You know, what are the options for doing that? So, yep.
That's great.
So we'll do it with brand, not just brand.
And with my background as a maternity consumer representative, we used to use brand as well, and the D was delay.
Right,
So so we'll have another workshop around that. But while I remember, please don't forget that you can submit your questions and your comments online using the speech bubble. Our team are busy behind the scenes feeding them through to me so that I can ask them of our panel. So, Harpreet, reliable estimates show that somewhere between 20 to 40, John referred to 30% of all healthcare is of little value to the patient or is totally unnecessary. This low benefit care has consequences for patients and families, which we will get to in a moment. Does it matter to patients and families if they are getting unnecessary care? Isn't any care or more care better?
Thanks, Melissa. Look, I think it really does matter if patients are getting unnecessary care, because in many cases it means they're not receiving the care that they need or that they really want. So often low benefit care occurs because the conversations with a patient, their family or carers, it hasn't occurred into what's of most benefit and value for that person. And this can lead to feelings of frustration, not being listened to or not understanding why their priority needs are not being addressed, which may greatly differ to the clinical or medical model of care. within a specific service. So without having open discussions, I think, with patients about what's most of value to them, assumptions are being made that in many cases are often incorrect or simply clinical focused rather than holistically focused. And so I guess when I say holistic focused, I mean, you know, the social, emotional, spiritual and cultural needs being met of an individual. And I guess if I provide an example with the work that we do, you know, for many Aboriginal people, getting back on country is the most important thing at end of life. And so interventions may be of not high benefit or high value for them. And like, you know, the fellow panellists today have said, it really varies for each individual.
Yeah, absolutely. Thanks, Harpreet. And I look forward to, at the next section of our panel, we'll be talking about those discussions and that shared decision making. So, Helen, often conversations about reducing low value care are focused on stopping clinicians doing to consumers. This might be true, it is true in some cases, but it implies that consumers are always just passive recipients of care. What role can they be empowered to play, as Harpreet said, to be part of those discussions to increase the quality of care that they receive? What is the usefulness of tools that Joan and Mornay have talked about that consumers can use to empower themselves to navigate conversations with healthcare providers?
Look, as a consumer, I use the Choosing Wisely tool. I carry the wallet card with me because I don't remember everything. And I think that's true of a lot of consumers, especially when it's an important topic we don't remember. But I think the most key thing for any consumer is to keep asking questions. But I guess the first question is, what will you do if you're not comfortable about asking questions? And there might be a lot of reasons for that. It might be that you need to take someone with you. You might need to have a list of what your questions were. Or you might feel that you just don't have that relationship with that particular health professional. And if that's the case, that you can't ask them questions, I would really be urging you to get a second opinion. You know, I learnt through my cancer diagnosis and treatment that a lot of people never get a second opinion for something major like cancer surgery and treatment. But we would get 2 or 3 quotes for a bathroom renovation. And I like to think that I'm actually much more valuable than my bathroom. So
that's a really, really good comparison. And it raises for me, I 1000% agree that the Choosing Wisely questions are useful. They're really important, especially for avoiding care. I had an experience supporting a consumer in the opposite circumstances. However, they were trying to receive care that they needed. And that's where I think Bran is useful. But as you say, that second opinion is really, really important. So it's about the right tool in the right circumstances.
And the right support. And sometimes it's from the clinician, sometimes it's from a friend, sometimes it's elsewhere.
Yeah. So, Mornay, in the NPS Medicine Wise program evaluation in 2018, the top 4 reasons that both GPs and specialists gave for getting unnecessary tests for their patients were patient expectations, blame the patients, potential for medical litigation, uncertainty regarding the diagnosis, and difficulty getting patient information from other practitioners. In a conversation in preparing for this panel session, you mentioned that shared decision-making plays a role in high-benefit healthcare. Consumers and practitioners working together consistently in this way is a fairly recent phenomena. How have you seen this shift over time during your time in medicine, and how can health staff be supported or trained to have these conversations?
It's changed a lot. You know, I think when I was a medical student or even, you know, as a junior doctor, you know, we had the system where the doctor knew best, you know, so that you get what you get. Is it important that we have these conversations? I find it a little bit ironic that we're having a conversation with an anaesthetist. As anaesthetists, we're not used to having conversations with people, but one of our initiatives, Q First, is actually about getting the consumer, the GP and the family engaged and have that conversation going so we can, and I think Joan has mentioned this before, what are your values, you know, what's important for you? And it also created a framework to educate our junior doctors to make them comfortable with consumers asking them questions. Because for them, you know, when a consumer asks them a question, it's like, how dare you? You know, like I've been trained for, you know, I've trained for 7 ADs. I know everything, you know, so they need to know that they need to be a bit vulnerable too, and give consumers the permission to ask those questions. And that's what we're trying to do. And it is quite difficult. It's very easy to say, you know, give a wallet card to a consumer to go and ask the questions. But I think, you know, like what you're saying is that there also needs to be education of our clinicians to allow that conversation to happen and not disrespect the consumer, etc. So I think that's challenging. I think it's changing. We do a survey every year, twice a year actually, with our junior doctors and our consumers, and I have to say the feedback's very similar to what you've mentioned, but it does look like people are feeling, especially our consumers, are feeling more and more empowered to ask questions. And just by having that conversation of people that presented for major surgery in a health service, out of 100 patients, only 30 ended up getting the surgery that they were originally planned for. You know, now that is consistent with what you've mentioned and John's mentioned before. And I think we need to, and that's just from having the conversations and talking about values.
Yep.
So absolutely, I think it's to get that two-way conversation going, and it has changed significantly for the good, I think.
Yeah.
Oh, good. That's reassuring to hear. Now, Harpreet, I've got a question here from John Michael. He has said brown is best as long as you have a good level of health literacy. What about minority groups who have trouble with English and access to appropriate translators? Why does the onus fall on the patient to raise the issue instead of, as John mentioned, and as Mornay has just mentioned, the clinicians are trained to provide this as a part of high-value care? Are there some tools or some education that can support called communities and people with low health levels of health literacy?
Yeah, look, I think it's a really good question, and there's a lot of gaps. Like, I think that it still kind of shocks me that the majority of Australians, you know, are either born overseas or have a parent or a family member directly that's born overseas. And with the, you know, the rate of English as a second language, you know, at homes, that there isn't the support provided. When it comes to, you know, communication campaigns, which we work on, the money is never there. You know, it's always the last sort of bucket of funding, along with Aboriginal communities. You know, everything's lumped into marginalised communities or other communities, and it's just not good enough, really, because you can't expect, without putting the resources into helping people be able to advocate for themselves because of the barriers that exist, to be able to then make informed choices about, well, what is the care that they want to receive, because the playing field isn't equal. So I think we've got a long way to go there.
Absolutely. It's not about equality, it's about equity, so that everyone's getting the care that they deserve. Absolutely. Joan, one of the barriers to reducing low-value care is time for these meaningful conversations that we're talking about between clinicians, consumers and carers. How can health services allow time for this and move away from just what feels like focusing on pushing consumers through the system that perhaps increases their chances of them receiving surgery and interventions that aren't helpful?
Yeah, look, time is difficult. I know that when I see my GP, we're on a 10-minute, you know, time basis, and anything more is a double appointment, which I do book if I feel like I want to talk to my GP, and she's totally fine about that. But I think what we're experiencing is left over from a patriarchal system where we believe that the clinician knows best. And so I would say it's a societal issue where, as consumers, our attitude has been that the clinician knows best, and certainly in the past, maybe the clinician has thought, well, you know, I've been trained to know that this is the best procedure for this particular ailment. But with values-based healthcare, it really takes all of that away, because as I said earlier, you know, what the best treatment for a particular ailment for different people will be different. And so working out what the best treatment is really does take time, like you just said. You really do need to discuss. I actually haven't used brand before, but you really do need to use, to take time and really talk to the person. It's quite interesting, like for my chronic condition, I haven't taken the suggested medicine because I was unsure about what the side effects would be for me and what the long-term, I guess, outcomes might be. So for me, even though I feel as though I'm fairly literate, I take time out to do, you know, so I'll have a doctor recommend that, you know, for my condition, this is what would be best. And I get them to write it down and thank them for it and go away and start researching. I talk to my friends, talk to support groups. I, you know, go on the internet. I use a whole range of different tools to inform myself and then book another appointment and, you know, and go back to the doctor to discuss, you know, what we talked about the first time. And as Dr. Wakefield mentioned, you know, if you're under really strict time constraints because, you know, it's an aggressive tumour or something like that, you need to act quickly, and that's really stressful. But in a lot of other conditions, we do have a little bit of time. So I would suggest not, you know, hastily coming to a decision. I would say, you know, that initial talk to the doctor and you know, seek recommendations because, you know, they're fully trained to offer these suggestions and talk about, you know, how that might affect you and use that brand model. But also go home and, you know, talk to your family and talk about what the consequences might be for your family. Maybe you won't be able to work. Maybe you won't be able to care for your children. Or, you know, there might be lots and lots of implications, and talk to your friends, maybe other people who have had, you know, that particular intervention, and then decide, you know, or go back to the doctor and say, you know, these are my concerns. You know, is there anything else? So that's how I've approached it in the past.
That's great. Thanks, Joan. And it's really good to have that reminder. It's not just about time with our clinicians, but it is that time to receive peer support, lived experience, talk through with our families. And what we've seen when people have experienced trauma through the system, it's often been when they haven't received all of the information of the risks of a treatment that they've received. But if they are given that and given the time to make an informed decision, that's a much better journey. There is a comment in line with what you were saying about short consultation sessions here from Maureen. She said that her local GP, they only get 10 minutes, so can only ask one question, and there are no other doctors to see in that area. Deciding to see another doctor is not an option in remote areas, and that's a really, really important thing for us to remember. And even in less remote areas, there can be 3-week waits to get in to see a GP for a short consultation. So access is a really big challenge, a very big challenge. Helen, I would like to follow up with you kind of the reverse side of the coin from what Mornay was talking about education of clinicians, but for consumers who may want something to be done, they may feel that intervention or surgery is the best thing, and maybe used to more working in that model of wishing to be told what the best option is for them. Sometimes they might be older people, but they can be any health consumer of any age. What would you say is the best way to support them to get the care that matters to them and is value-based and evidence-based for them?
I really think it comes back to conversations, lots of them. It's quite interesting at the minute. In my family situation, my father is quite elderly and has just moved into aged care, and we're looking at all sorts of end-of-life issues. And as a consequence of that, my daughters and I are having discussions about my end of life. And that's not as horrible as it sounds. It's just we'd rather all be prepared. And I know this about my dad, but do you know this about me? You know, Dad's decided this, but I've decided something different, did I tell you? And that takes a lot of the stress away. People get set in their ways, but it doesn't mean they won't listen. It just means that sometimes you've got to try more than one way for them to hear. I think back to antibiotics is a classic. Once upon a time, it was automatic. You went to a doctor, you got given an antibiotic. And that was a mixture of consumer expectation and clinician, that's what we do. That's changed, and it's changed quite radically. But it took a lot of work and a lot of conversations, not just one-on-one, but in the media and amongst parents and, you know, everyone talking about the consequences of lots and lots of antibiotic use leading to resistance and that sort of thing. But on the other hand, as everyone keeps talking about with value-based care, I can remember one specialist explaining to me that the research was showing that antibiotic treatment didn't make a huge difference to a child with an ear infection. And I just looked at him and said, you can say that as much as you like, but I've had children with ear infections and they're getting antibiotics because we needed to sleep. We needed to reduce the pain quickly. And yes, the research shows that all the antibiotics achieved was to shorten the painful period by a couple of days. But a couple of days had a huge impact on our quality of life and sleep. So, you know, evidence on its own isn't sufficient.
Yep, that's a beautiful quote. And I think your example of a growing community understanding around antibiotics resistance is also in line with what we've seen with COVID. So it's been an incredible opportunity to grow public health knowledge and health literacy amongst consumers. And it is why there's been such a high level of engagement around the vaccine and people wanting to understand the benefits, the potential side effects and make an informed decision. And sometimes when it's referred to as vaccine hesitancy, I feel frustration because I think it's actually high levels of health literacy growing in our community, and let's harness that and apply it to other areas of people's health.
And I think too it's a really great demonstration of the impact of media and media stories on health literacy, and we really need to be sure that the media is giving both sides of stories and giving, what's the best word, you know, information that's valid, not just what will sell the latest newspaper, which is old technology, but still.
Balanced, yeah.
Yeah, thank you.
I do want to move into some discussions around care at the end of life, but we have a quote here from, a question here from Joe. I wonder if it's our Joe. If value-based healthcare is just about what is of most benefit to the person, isn't this what person-centred care is? What is the difference? Would anybody like to answer that? Have you thought about that? I have to admit, I haven't consciously thought about that.
I think it's exactly that.
But it is.
I think, you know, for one person, a hip replacement may be the perfect procedure. For the next person, it may be the worst thing you can do to them, even if you do it technically perfect. You know, it's really putting the patient in the middle and having that conversation. So, yeah, I think so. I think that's a very good comment, yeah.
But the thing...
Can I add?
Sorry,
Sorry. I agree, but I think that the term value-based has more power behind it because I think with patient-centred care, which I agree with you, Mornay, is I think we're all talking about the same thing, but I think it's sometimes missed that what we're actually doing is talking about, well, what is of greatest value to that patient? And it gets lost, I think, in the terminology and the way things operate and in the systems and in the, you know, under-resourcing and everything else that, you know, happens in care. And so I think maybe there needs to be a shift in terminology or the meaning of, well, what is patient-centred care, so that isn't lost.
I agree. And I think it's important to tie in with things like evidence-based. You know, Dr. Wakefield talked about the percentage that's not necessarily of high value. But what worries me is the period of time, which can be up to 7 years, for good evidence-based practice to become entrenched within our practice.
Yeah, it's not easy. I think it's also going to challenge the way, you know, and I'll go back to us adding the D, you know, is how do we deliver care? It's not only about what care you deliver, it's where do you deliver care, you know, and you know, coming from South Africa originally, you know, you come to Australia and, you know, you're 150 kilometres west of Brisbane and it's like you're in a different country.
Yeah.
You know, so I think there's challenges with that too. If we say we support our consumers and, you know, and what's the value in it for them, it looks very different in the community in a rural community than it looks in Brisbane, for example. So,
But it shouldn't be a postcode lottery everywhere.
yes, I agree. But it is.
It is. It is. And, you know, there are lots of in-between places in regional areas that don't have consistent GP service. They have locums or, you know, rotating GPs and things like that. And we know that doesn't lead to good practice.
Absolutely. So there's a really great follow-on question here from Beyonce. Why is it that so much care is unnecessary or of low benefit? It's because doctors are recommending care that isn't evidence-based care. How do we change practice and ensure doctors remain skilled and not just keep doing something that was standard practice 20 years ago but is no longer valid? What are the tools and the levers that the system has to prevent that? Surely it has a responsibility.
Yes.
Clinical guidelines?
Clinical guidelines, what have you, you know, just changing expectations, I suppose. The one thing that I think clinicians find very difficult is the end of the brand questions. It's the what if I do nothing? You know, we're not really trained to not do anything. So you chase that rabbit down that hole until you find something you can give a name. You know, so it is a way in which we train our clinicians too. So that needs to change. You know, that doing nothing is maybe the best for your particular patient. So, but it will take time, I think.
And I think medical education's critical, because even when our clinicians arrive in hospitals, and they get a lot of their on-the-job training in hospitals, but they're in a very hierarchical structure. They do what they're told. They often don't have any discussions about the cost impacts or any other impacts. They have limited time. They have so many things to get done. And, you know, it's really hard work, because the systems that manage university training and hospital training and then out in the big wide world professional development training are all different, and I'm not sure that they talk to each other.
Can I make a comment on, Helen, what you just said? So we do the survey I was talking about earlier about junior doctors. 90% of our junior doctors know that we do things we shouldn't. 90%. 60% of them do them because the consultant may ask for that result. So you're absolutely right. You know, it's that generational change between, the professor and the old guard and the young ones coming in. It's a challenge.
Melissa?
Yeah, Joan.
Can I just add in there? I think de-implementation research is really important. I've been involved as a consumer with research that's looking at, removing non-evidence-based practices, which is not new, but still a really important research, because quite often we're looking at what new practices might be. So in particular, we're looking at, what we can take out to ensure it's evidence-based. I agree that there has been a real expectation from consumers that we want something done. And, if we go to a GP, we don't expect to walk out empty-handed. But I know for me that sometimes information, I'm happy to walk out with information, not a magic bullet. And so maybe that might be a good approach to future healthcare is, looking at, an outcome might be to be more informed, not a silver bullet. So if I walk out from a GP, just knowing a little bit more about how I feel, and, maybe I haven't had any tests done, or I don't really know what's wrong with me, but maybe I just feel a little bit more informed that that's okay as well. So there's probably, two aspects to that, one from the consumer's point of view and one from the clinician point of view as well.
And if you can come out feeling informed but also validated, and that someone asked you what matters to you, and let's go on that journey together to help you get that outcome.
And there's potential for that in things like, the asthma plans and the diabetes plans. We do it for some chronic health conditions, but we should do it consistently for everybody.
So look, let's move into discussions on this topic around end of life. Harpreet, care at the end of life is something that you're passionate about, and you have expressed frustration at the idea of extending or preserving life at all costs. And it's an area where unnecessary procedures occur. When a loved one is nearing the end, it can be very distressing and confusing for family members having to make decisions on medical matters if they haven't had those conversations that Helen was talking about beforehand. To what extent does healthcare providers' discomfort or inability to have the conversations needed create the conditions for low benefit care being offered?
Big question, thanks. Look, I think to start off with, the discomfort around conversations when it comes to end of life lie with society as a whole, broadly. And many people, you know, are uncomfortable with having conversations or planning for end of life, but I think this is slowly shifting. So I think the preparation lies with all of us, and that includes service providers or healthcare providers. You know, I think we know that our medical system's geared towards prolonging and extending life. And so, you know, in my experience, when someone's diagnosed with a life-limiting condition, like all efforts go into immediately problem solving and usually seeing what can be done to extend life. And there's been, you know, numerous cases I know of where people have shared stories about feeling pushed to continue with treatment, you know, when deep down they feel that it's futile and they don't feel they have a choice. So it comes to that voice, you know, and the ability to speak up. And I know in my experience, again, I've heard health providers say that they don't want to feel like they've failed, you know, when in fact we've all got limited time here and death is inevitable one way or the other. So I think it's important that power and agencies handed back to patients and families to decide individually what's of most benefit to them. And this might not be treatment, just like Mornay said, you know, maybe it's doing nothing. And that's really hard. It's really hard to do nothing, and it's really hard to weigh that up. But I think these conversations need to be ongoing with patients, families and carers and revisited, because it's a lot to digest at end of life. You know, it's a lot to receive a diagnosis, sit with it, and then be told you must, or this is the best option to go down this rabbit hole of treatment, when in fact maybe that's not the best for that person, or they need time to sort of sit with it. And so I think we need to work towards ensuring like all healthcare providers, not just palliative care, like all healthcare providers are comfortable speaking truthfully and openly about all options in disease management and what the reality of life prolonging treatment might look like. And for those decisions to be made jointly. I don't think people are deeply listened to or given the time to consider what they want, so they can make informed choices on how they want to live their life with the time that they've got.
Almost one of the most important decisions we'll ever make, that as Helen said, we might be the least supported to do so. Thanks, Harpreet. Helen, Harpreet referred to palliative care in her response. How does high value care at the end of life fit in a continuum of advanced care planning, palliative care, and with the draft legislation going to the Health Parliamentary Committee at the moment, voluntary assisted dying?
Look, you're right, it's a continuum. And I'll come back to conversations. You're not going to get things happening at the end of life if you haven't had those earlier conversations all the way along. And it's the same with voluntary assisted dying. It's important that it's come before Parliament, but we should be talking about it. You know, it's quite interesting. My dad and I had that conversation because he's a very committed Catholic, and he said, well, I wouldn't. But he said, the church says it's all right for me to refuse treatment, and that's what I want to do. So, you know, we had that discussion because we were talking about voluntary assisted dying. People are different, people are complicated, but if we don't talk about it, it'll never happen. And it's not an easy conversation. It's, as Harpreet said, none of us are comfortable. I had a friend who died of cancer quite a few years ago, and her husband basically shoved me into the room and said, you need to find out what she wants done for her funeral. And we had a very teary conversation about death. We didn't actually talk about her funeral. We talked about what would happen to her after death and things like that. And it was a very powerful conversation. Her daughter came in partway through, and it was a gift to all of us that we had that conversation. But it was a terrible way to start it, you know, being shoved in there and saying, talk to her because I can't. But that's our reality at the moment.
Absolutely, culturally. So, Mornay, as a doctor, you have had conversations with patients and families to share decision making. Some of those conversations must be quite difficult. What are some of those difficulties that doctors face with conversations around the end of life? And how does your approach, or the approach of those that do it in the way that Harpreet described, makes those conversations easier?
Thanks, Melissa. It's probably why I got involved in all of this. As an anaesthetist, you know, by the time, often with emergency surgery, you know, by the time the patient gets to me, it's at the end of many conversations and discussions, and it's very difficult. It's a bit like that boat that got stuck in the Suez Canal. You know, it's very difficult to turn things around at that end. I agree with Helen. That's too late to have those conversations. What I often find is that when people do end up in that situation, it makes it very difficult for families, because they often feel guilty. You know, they haven't had those conversations before, and the last thing they want to be seen as doing is giving up on a family member. It makes it very difficult for them to say, you know, do nothing and make my mother or father, you know, comfortable only. So I know Helen keeps saying, you know, conversations, but I totally agree. And we've got this conflict, don't we? Because most of the medical research we do is to see people survive for longer. You know, our whole social media and our social makeup and framework is about longevity and being healthier for longer. You know, it's sort of, it's like we try and evade death and having those conversations. So I agree. I think it's everyone's responsibility, and it's you know, I feel so sorry for that junior doctor on their first night on call at 4 o'clock in the morning. You know, to have these conversations with the family, and what are they going to do? They're going to do everything. You know, to make a decision that's going to end someone's life is very difficult.
And we've got the help. You know, paperwork. When I first looked at end of life paperwork, I put it all away again. I said, there's too many forms, there's too many questions, they're all too hard. But when I got support to step through one with Dad, and we used in particular the a values-based questionnaire that's available through Queensland Health, that really helped, because instead of asking him about resuscitation first, we talked about what made life worth living, what was important to him, what were his values.
Yep.
And that's, I think, part of the conversations we need to have. What's your quality of life like now? And when you're talking about brand, what are the benefits to your quality of life? Because that's the conversations that we need to start with, so that we can then make the final decisions.
Can I just add to that? And I've had personal experience of someone who was diagnosed with a terminal illness and needed surgery. It was very unlikely that they would be better after the surgery. They were going to definitely be worse. But they were looking, this individual, this poor man, was the primary carer for his wife. And we could not guarantee that he would be able to go home afterwards and look after his wife. For him, that was the most important thing. So he was comfortable with going home and look after his wife for an extra 3 months and get his affairs together. And I think, you know, that was a very brave decision on his part, but I think, you know, it's not just about dying, it's that quality of life and what happens afterwards.
Yeah, it was the right decision for him, yes.
Yeah.
And Helen, can I ask, was that the statement of choices
Yes,
document?
I couldn't think of the name.
So we'll make sure we include that when we publish this recording. We'll make sure that's in.
And there's a particular version that I would advertise. It's redeveloped by the consumers up in the Torres Strait, and it's a plain English, a very, very plain English, and it's a really accessible version.
That was the version that you used? Oh, great, that's great feedback.
And it's great because it talks to the heart, not to the... It's a difficult conversation, and because I have renal problems and I talk to a lot of other people with renal disease, we constantly go around in circles with this when the conversations are not done well, people feel like, oh, you don't care if I die or not. So they've got to be done well.
And I'll ask one more question in this area, and it's to you, Mornay. Is part of the concern of doctors doing nothing around a fear of litigation? So we've got a question here from Graham. Will the do nothing option ever get enough focus if the fear of litigation looms over doctors, whether it's end of life, whether it's around not providing a certain surgery or test?
Absolutely, absolutely. And what makes things more complicated is that the law in Queensland is, for example, different to the laws in New South Wales and Victoria. And what you can and can't do, you can't refuse care, but you can't provide futile care. But then you have, whether you like it or not, that's why I'm here. You've got all these doctors from overseas. And the one thing we know is that the public hasn't been, or not the public, I should say, social media and the media hasn't been very kind to foreign doctors in the past, when they make a mistake. So there is that fear of doing the wrong thing. So I'd rather do a little bit extra rather than not doing enough and getting into trouble and ending up in court. That is, and in my safety and quality job, I see that all the time.
Yeah.
And the doctors are nervous. And I have to say the coroners have not once ever said, they should have done more of this or that. It's usually, why did they do X, Y, and Z? Why didn't we stop earlier? So it is a perception, maybe not completely true one, but it is certainly a perception. It is a problem.
Yeah, that we need to overcome through education.
Yep.
Yeah. Well, it's been so clear through our session that we all know the kind of care that we want Queenslanders to get. We know there's support for value-based healthcare right up to the top from John at all levels of the system. But why is it so hard to scale and spread these initiatives that are high-value care? So I'd like to have a conversation around system change and so a social movement around this. Joan, we want this to spread at scale across the system, but we see inertia and inaction. Is funding the major barrier to implementation? Should we just be calling this what it is, low value, poor, non-evidence-based practice? And how do the consumers and the system change the funding models that reward poor care?
Yeah, the funding, that's a little bit beyond me, but while activity-based funding is a thing, certainly clinicians will be doing activity to make sure there is funding. So I guess that there does need to be another view on how funding is allocated, and maybe it's to do with quality of care, person quality of care as opposed to activity-based funding. But definitely activity-based funding only enhances and draws to a focal the, low-value care because that activity is rewarded. But I do think it is a cultural shift that needs to happen, whether it's the training of doctors or, as Mornay was saying before, he said that junior doctors know that actually they're doing practices that they shouldn't be doing. So there absolutely needs to be cultural changes within the system that need to reward people for only delivering high value care. But also, I know one of the questions earlier said, well, why does it fall on, the consumer to ask these questions? But I do think it is really important that we are empowered with our own health. We shouldn't be expected to know, what the best practice is because, we're not experts in healthcare. But we should definitely have some responsibility in asking the questions and feeling like our questions have been answered so that we can make informed decisions as well. I think it's really two-way. I don't think it's one way. I don't think we should only depend on clinicians to be delivering high-value care. I think there is some of that should fall on us as well, just to be asking those questions and to feel like, we're getting care that we think we require.
And it's important for us to recognise that that will be different depending on who we are. So there is a comment from the audience here that we need to recognise, especially in Queensland, the different questions that people in rural and remote Queensland need information on so that they can make decisions that are right for them. Where can I get this done? How will I get there? How much time away will I have from my home, work, life and family? The answers to that are going to be different for everyone.
Absolutely.
Melissa, I just want to add to that. I grew up in regional Queensland, to a family of immigrant Italian, family, and certainly with really low health literacy and low English literacy as well. And my father had a chronic condition. He had type 1 diabetes. And I know from a really young age, like access to information and access to healthcare on the Atherton Tablelands in the 80s, not even that long ago. It was really tough. So I look at, the healthcare that we have here in Brisbane on the Gold Coast, and it is amazing. And when I talk to my mother, who is still in Mareeba, and she tells me that there is no bulk bill doctor, and they pay, full for whatever the query is. I've just find that amazing. My local GP bulk bills and all the doctors within that GP bulk bills, and so access within Queensland, as you just said, is so different, and everyone's requirements are so different, and people's literacy is so different. It's so hard to comprehend. Here we are, talking about it in a very sanitary type of way, but it is a really, like you just said, it's regional and it's community, and there's vulnerable groups, and there's lack of access and lack of literacy as well. It is a really complex issue.
It is, and we have telehealth now, more telehealth than ever, but that's not always right. It's not always the care that people want to receive. Thanks, Joan. Helen, how do we make this a social movement that gets political buy-in and creates that change to how healthcare is funded and delivered?
Start a revolution. Look, it's really difficult because I think most people don't really understand our health system, and they certainly don't understand the funding. And I think that's true whether we're talking about clinicians, consumers, and particularly here I separate out administrators. And it's nice for us that we've got a Director General of Health who's been both, because I think that helps. But we've got federal funding, we've got state funding, we've got private hospitals, we've got private practitioners that run small businesses. GPs are essentially small businesses. And we've got public systems and public clinics. And they're all different, and they operate under different frameworks. And then on top of that, what often doesn't get considered is the impact on other systems, like education. If we make people wait for surgery, what does that do for their education and training? Cataract surgery is a classic. I've never understood why it's called elective surgery. A person can sit there blind waiting for their elective surgery, unable to work, unable to drive, but it doesn't cost the health system anything, so it doesn't matter. But it does, because that's not person-centred care, and it's not valuable care for anyone, and there's of no benefit to anyone to leave people waiting for surgery that would so much significantly improve their capacity to be part of our community. So we've got a long way to go.
We certainly do. And Harpreet, how will we know when we get there? How will we know that we've transformed our healthcare system into one that consistently delivers high benefit care? How will that healthcare feel and look like for the consumer and their family?
Well, I think for me, I think we'll know this when we're not hearing story after story of patients and families saying that they're not being listened to. Because I think going back to the comment that Joan made about, her family and growing up on the tablelands, like no one will know us better than we know ourselves. And yet I think often, when we're there lying in a hospital bed or something like that, we're not truly deeply listened to. We're the ones who are experts on our own bodies and our minds, and we should be treated as so. And so I think when we get there, it'll be a situation where the whole of community trusts healthcare providers to know that the decisions that will be made about our healthcare is patient-led, And so, it's a situation where distress and confusion will make way to community and health providers feeling like we're working together with shared power. And one where our system isn't being overburdened with emergency care and interventions, due to problems being missed or people being treated when recovery is futile. I think when I think about it, it's when people can live their best lives and feel safe, heard and supported.
Well, that's wonderful. And Health Consumers Queensland looks forward to continuing to work with all of you and so many others that share that vision to make it a reality. So thank you all so much for being part of the panel today. Joan, Mornay, Helen, Harpreet. It's been such a valuable conversation, and I'm so pleased that we'll be able to continue to share it with the online recording that will be available tomorrow. So I'm really sad that this is all we have time for this episode and for this first series, but hopefully there will be more. Thank you to everyone who's been a part of our first series of HCQ TV, our panellists, our previous panellists, Queensland Health for their generous sponsorship and support, the Director General tonight of Queensland Health, Dr. John Wakefield, our event partners, Iceberg Events, who have supported us with the very smooth organisation of our online annual forum event. Select Audio Visual here in the studios at Wollongabba, where we've been live broadcasting all of our episodes. Thank you for just making this experience a dream. And to our team here at Health Consumers Queensland, particularly Suzanne Werges, our engagement advisor who coordinated HCQ TV this year. Thank you so much for your tireless work in making this a reality, and thank you to our board for supporting us to make this happen. Thank you to all of the staff and consumers that we work with right across Queensland. You're the reason that we do this. Thank you for sharing your experiences and your passion for a consumer-centred healthcare system that delivers true value-based care shaped by and for Queenslanders. You can continue to connect with us through Facebook. You can re-watch these episodes on our website, sharingpower2021.com.au. Continue to get involved in all of our opportunities that we share, and we look forward to seeing you soon. Thanks, everyone.
Thank you.